Well, good morning, and thank you all for coming here nice and early. I just want to first start out by saying that I can speak for my other three colleagues who see patients here, that we're all very happy seeing patients here. We're always impressed with the level of care, both medical and nursing, and how friendly everyone is, which is not something you always see in hospitals these days. So we just kind of want to, we don't always get a chance to talk face to face, and not that we're facing everybody here that we interact with, but we just wanted to get that point across on behalf of Dr. Larrabee, Dr. Halpert, and Dr. Hamdy, and Dr. Sullivan, who I think I used to see patients here, but isn't much anymore. Okay, so I wanted to start out my talk on perioperative care of the diabetic and endocrine patient by showing a simplified graph of different insulins that we have available and that we use in the hospital. The rapid-acting insulins start to work really within about 15 or 20 minutes, peak at about 1 hour to 2 hours, and last about 4 hours. And those are Aspart or Novolog, Glulisine or Apidra, and Lispro or Humalog are the brand names. Regular insulin is an older insulin. We still do use it in certain situations. And that has a little bit of a slower onset of action, about half hour to an hour. It peaks more from 2 to 4 hours and lasts usually up to 6, maybe as much as 8 hours. NPH insulin, the older basal insulin that we don't use nearly as much of anymore as we do the true basal insulins, but NPH insulin usually starts to peak somewhere around 4 to 5 hours, has a much broader peak than the other insulins. The peak can last up to 8 or 10 hours. And we usually think of it as lasting about 12 to 14 hours, sometimes even more. And then this idealized form, this idealized graph here of glargine or detamere, or Lantus, or Levemir insulin, has a slow onset of action, but presumably or ideally no real peak. I think there is still some peak that occurs with these insulins, but certainly much less so than with NPH insulin. So about 4 years ago, the American Academy of Clinical Endocrinologists and the American Diabetes Association came out with a joint set of guidelines or statement on goals for managing patients in the hospital. I think it's worthwhile just reviewing those at the beginning of our talk. This is for non-critically ill patients. For the majority who are treated with insulin, glucose targets should be less than 140 before meals and less than 180 at random readings, provided that these can be safely achieved. And I think that's important to keep in mind when we're dealing with a varied group of patients. More stringent targets may be appropriate in stable patients with previously tight glycemic control. So there's certainly patients who are used to blood sugars of 100, 110, 120. And if the clinical situation warrants continuing those goals in the hospital, I think is reasonable. Less stringent goals are certainly more appropriate in terminally ill patients and in those with severe comorbidities where hypoglycemia would be a dangerous occurrence. And there are certainly many patients that we see here, as well as I see at Beth Israel Deaconess Medical Center when I'm on service there, that would fit into this category. Scheduled subcutaneous administration of insulin with basal, such as glargine or detamere. Nutritional, usually with a rapid-acting insulin. And by nutritional, we mean insulin that's given to prevent blood sugars from rising when someone eats. And correction, which is insulin that's given to lower a blood sugar that's high before a meal. So we usually give one dose, but really implicit in that dose or built into that dose is both a nutritional and a correction component. And that's the preferred method for achieving and maintaining glucose control. Prolonged therapy with the quote-unquote sliding scale insulin. And I put in my few words here, which is as correction only, because I think that's what everyone means when they talk about sliding scale insulin, starting at a high blood sugar of 200, let's say, and just being used to correct what we did wrong at the previous meal. That is to be discouraged. I think in most situations, and I think some of the patients we see here I feel are kind of an exception to this rule, and maybe we'll get to that a little later. Non-insulin anti-hyperglycemic agents are not appropriate in most hospitalized patients who require therapy for hyperglycemia. But again, a lot of the patients we're seeing here on the surgical service, they're post-operative patients, and a lot of times they're eating by the next morning. and I think it's usually a good idea to get them back on their oral agents if it's safe. There we go. Clinical judgment and ongoing assessment of clinical status must be incorporated into day-to-day decisions regarding treatment of hyperglycemia. So we're therefore always eager to see the patients, usually daily, or at least have some idea of where their blood glucose values are daily. So we appreciate the meticulous glucose checks that occur on time with all of the patients that we're following. Over-treatment and under-treatment of hyperglycemia certainly represent major safety concerns when we're seeing patients like this in the hospital. Now for critically ill patients, that was all for non-critically ill patients. For critically ill patients, the guidelines state to start insulin therapy to treat persistent hyperglycemia using a threshold of no greater than 180. So if patients are in the ICU and their glucoses are running above 180, we should be doing something about it. Once insulin therapy has been started, aiming for a glucose range of 140 to 180, and that comes from a study, the NICE sugar trial, which I think I discussed here a few years ago when I spoke on a similar topic. Validated intravenous insulin infusion protocols, which have demonstrated safety and efficacy, and with low rates of hypoglycemia occurrence, are recommended. There are a lot of different insulin protocols that are available. The ones I think I prefer are ones that look both at the previous hour's glucose value and the current glucose value and adjust the rate based on the decrease or increase or rate of increase or rate of decrease of blood glucose value. And I think those are important to use as opposed to some of the less sophisticated ones. With intravenous insulin therapy, frequent glucose monitoring is essential to minimize the occurrence of hypoglycemia and to achieve optimal glucose control. So this is a summary of the last few slides. Essentially in the ICU, we're aiming for blood sugars of 140 to 180. And in the medical and surgical units, we're aiming for readings around 140 or below if we can get there, and random readings below 180. And most of our readings really are pre-meal. They're not too many that are random, but those are the goals. In the hospital setting, insulin therapy is the preferred method for achieving glycemic control. In the ICU, intravenous insulin is the preferred route of administration. And on the surgical wards and medical wards, subcutaneous administration of insulin is frequently used and recommended. And orally administered agents have a limited role in the inpatient setting, but I think that's more in patients who are more unstable medically than a lot of the surgical patients that we see here, or we're talking about perioperative management. So I don't think it always applies to these patients. Certainly patients who are eating or expected to be eating, I think the oral agents do have a role. So my goals when I see a patient, when I'm consulting on a patient in the hospital, is to think of them in the three tenses, past, present, and future. So I want to take this opportunity when I see a patient to see what's been going on before they came into the hospital. Now, if we see the patients a week or two or three before, which I think would be a good idea, which we don't always do here, we could get a sense of what's going wrong and maybe fix it before they come into the hospital. So we already know that they're on a good regimen when they come into the hospital. But be that as it may, knowing what's going on at home, I think is important. And of course, the present, we want to avoid big swings in glucose. While they're an inpatient, we want to keep their glucose values in the ranges that we've spoken about, and want to make sure that we don't give them any medications that cause any problems. And then another important part of our care here is discharge. So future, what regimen have they been on? What regimen are they on here? And what is a realistic and a good regimen for their glucose control that we can design for them before they leave the hospital? So in the past, so if we see a patient, we want to know what their hemoglobin A1C is at home. We want to question them if they're having any hypoglycemic events at home. How frequent are they? In what setting are they occurring? Are they when they don't eat? In which case we might want to think about those when they're in the hospital when they may not be eating. Or are they occurring too often or all of the time, daily, let's say, and they wouldn't be, we need to know about that in the hospital. Might want to use that to change our insulin regimen or our medications that we're treating them with. Are their medications appropriate? If they're on metformin, which I would say probably 80% of the patients that were consulted on here who are on medications for diabetes are on metformin, is their renal function adequate? There was a paper a few years ago in Diabetes Care by Inzuki et al., who was my clinical preceptor when I was a fellow at Yale, where he suggests that relaxing the creatinine clearance levels a little bit down to perhaps 45 as opposed to 60 are warranted for metformin use. So if patients' creatinine clearance is 45, 50, and they've been on metformin for a long time, you probably can continue the dose. You might want to decrease it. But knowing what their renal function was at baseline is important, and of course following it in the hospital. Are they on a TZD, which we don't use too much of anymore? Rosiglitazone was used a lot. It was kind of essentially off the market, although not technically so. Now it's I think officially back available, but not too many people are using them anymore. But there are some patients I see here who are on pioglitazone or Actos, and are these patients experiencing edema or fluid overload? Are they on the wrong medication? Should we make a change? And probably the most important thing I think I do when I see a patient initially is assess level of compliance. Are they on a medication regimen? And this obviously goes for any type of medication, for any for other medical conditions as well. Are they taking the medications appropriately? Are they able to? Are they willing to? Is there some side effect that they're experiencing that they don't want to? They're not talking about, and therefore they're not taking the medication. So I think these are simple things that are important to assess when we see the patient. So the present. So when we are following the patient in the hospital, if they're surgical patients, which most of our consults here are, we want to resume their oral medications when they're eating, and if they're on metformin, when their kidney function is assessed to be okay. I usually check it the next morning. One could argue that we should be checking it a day or two later also, but in some way we should be assessing their kidney function and deciding if they're able to resume the metformin, or if there's some reason why their kidney function has declined, and not use metformin in that situation. If they take insulin, we want to resume it when their oral intake increases, although, as we'll talk about in a few minutes, using basal insulin more to take the place of some of the oral agents is also a useful approach in a lot of these patients. And depending on how much insulin production how much endogenous or endogenous insulin production they're still doing on their own, these patients, we would start to introduce or reintroduce their bolus insulin if they're on that at home when they're eating, as opposed to when they're not eating, because that might induce hypoglycemia. We always want to avoid low blood sugars. They're unpleasant for doctors, they're unpleasant for nurses, they're unpleasant for patients, first and foremost, and they're probably dangerous. So we want to do all that we can to avoid that, and I think some of the dogma around using sliding scales that start at 200 is probably has developed because people are so concerned about hypoglycemia, so we're always under-treating. But some of the data that a couple of the studies I'll present to you, suggests that that we can be a little bit more aggressive in this regard and probably not have too much of a risk of low blood sugars. And as we're getting towards the end of their hospitalization, does the patient need insulin as an inpatient, and do they need it as an outpatient? So based on what they came in on, based on what their A1C was, if their A1C was below 7 when they were admitted to the hospital, likely that they don't need much insulin in the hospital to control their blood sugar unless they're being treated with high-dose steroids or something else, or they have an infection or something else that's going to increase their insulin resistance. But oftentimes these patients really don't have much need for insulin, certainly as an inpatient and also as an outpatient. One thing that's always important to keep in mind when we're seeing patients who are truly type 1, and I would say that's maybe 10% of the patients we see, or probably less, is that they always need basal insulin. Even if they're not eating, even if they're nauseated, even if their blood sugar is 150 at night, before they go to sleep, if they don't get any basal insulin by the next morning, they potentially could be in DKA, or their blood sugars could be very high. So true type 1s do need basal insulin. And true type 1s need prandial insulin whenever they're eating, because they don't make any insulin or make minuscule amounts of insulin on their own. Some and many type 2 patients who have very little endogenous insulin production certainly need prandial insulin and probably basal insulin if they're not on their oral agents as well. So this is a study that was done in 2007. I believe this was the RABBIT-2 trial that was done, led by Guillermo Upierrez from Emory University in Atlanta. And it looked at medical patients. And we'll talk about the surgical part of this study as well. But they were non-surgical, insulin-naive patients with diabetes over 3 months. Their blood sugars on admission ranged the whole gamut from 140 to 400. And these patients were randomized regardless of what medications they had been on, whether they were on diet or oral medications, they were not on insulin, to basal-bolus therapy with glargine and glulisine. So the basal was glargine, the bolus was insulin was glulisine, or Pedra is the trade name. And they were randomized. Their glucose control was managed by either sliding scale, the typical sliding scale, which is just a correction-only scale. I believe it was starting at 180 or 200, versus basal-bolus therapy, where they did a weight-based algorithm and they determined how much insulin the patient needed by taking half. It was 0.4 units per kilo per day, and they figured out how much the patient would need. They divided that in half for the basal, so they would give them that much glargine, and then the rest was spread out over 3 meals with some type of graduated scale for meals when they were eating. If they weren't eating, they weren't given the prandial insulin. And they were given supplemental insulin, as I mentioned, if their blood sugar were elevated. And this shows that with the open circles are the sliding scale, essentially the sliding scale only, the correction-only scale, had higher blood sugars, versus the basal-bolus patients had overall lower blood sugars, and it looks like they're on average about 50 points lower in this study. Now, I had some technical difficulties with the RABBIT-2 surgery side, which was published 4 years later. So I just printed it up, and I think I'll just present you some of the material verbally. They looked at patients who were on the surgical service. There were about 200 patients in the study that they did, and 76 were listed as cancer patients. 59 were listed as GI or benign GU patients. 31 patients were listed as vascular, and 38 as trauma. Of note, these patients, only about 10% of them were treated with diet alone for their diabetes. About 70% were on oral agents, and about 12% each were on insulin alone or insulin and oral agents. So I would argue this is a little bit different than the group of patients that we see here. I think we may have, at least the ones that were consulted on, maybe a little bit more that are on diet alone. And oral agents, probably about 70%, but I think we have a little bit less than that on oral agents, and maybe about the same amount on insulin. And essentially what they did was they randomized them to a similar type of protocol, sliding scale insulin only versus basal insulin and bolus insulin with a weight-based algorithm like I had mentioned, although what they used a little bit more insulin in their algorithm. I think it was 0.5 units per kilo versus 0.3 to 0.4 that was used in the medical study. And this was essentially the results, which showed that the patients who were given the basal-bolus therapy, their blood glucose levels were lower. And these are the patients, again, that were given the sliding scale insulin only, and their blood glucose levels were higher. And they also showed in this study, importantly, that the rate of wound infections and some other complications, including pneumonia, but I think the most prominent one was wound infections, was lower in the group that was on the basal-bolus regimen versus the group on sliding scale. Now, there weren't a lot of orthopedic joint replacements in this. In fact, I don't think there were any. So one could argue that we can't necessarily compare it to our group here. And that maybe is why we're not using as much basal insulin in patients who come in on metformin alone, because probably they usually don't need it. As I mentioned, if their A1C is below 7%, a lot of times they'll do fine without much overnight, and then they'll start their oral medications the next day. There was a slightly higher risk of hypoglycemia in this study. I don't think it was there wasn't one, this was not seen in the medical study, but in the surgery study there was, and they postulate that that could have been because a lot of the patients were obviously eating less overall than medical patients because they were post-op. But be that as it may, they didn't get too concerned by the low blood sugars. They didn't seem to have any adverse sequelae from it, and although they're unpleasant to see and observe, they weren't fazed by it, apparently. So those, I think, are two of the important studies vis-a-vis the questions that we grapple with every day in the hospital when we see these patients. And then the last step in our evaluation here of these patients is the future. Plans for rehab stay. Will the patient be going to a rehab? Will the patient be going home? Will the activity level and intake of food be similar to what they were doing at baseline when they came into the hospital? Or will it be less? Or will it be more for whatever reason? And that's especially if patients are on multiple medications and or multiple insulins or high doses of insulins. It's always tricky to make that transition from preoperatively to immediately postoperatively to prior to discharge to going to rehab to going home. And we can be involved in everything from pre-op to leaving the hospital. We're not usually involved in the rehab and going home part unless we're following them. So that part I think can be tricky, and it involves the page 1 and giving everyone the correct instructions, and that's I think a place where things can get confusing and messed up. I usually will tell patients that if they're monitoring their blood sugars and they get 2 readings over 250 in a day, to call me. That doesn't necessarily mean that if they're not at that level, they're doing well. But I think it does usually mean that if they're at that level, they should probably call someone, either myself or their regular doctor. If they have a regular doctor that manages this, I tell them to call them. But I think patients should always have a fail-safe someone to contact if something is going awry, because we can't always anticipate what's going to happen in the future. It's always important to use what we've seen in the hospital and what we know they were doing at home and kind of come up with a reasonable and realistic approach. A lot of patients will see that their basal-bolus therapy in the hospital works better, but is this something that they can realistically do at home? If they use a mix twice a day, that might be simpler for them. Is this an elderly patient that can't inject the insulin on their own, and they're relying on a family member who's there in the morning or who's there at night to help them with? So these are all things we have to take into account. And another good opportunity to take advantage of when we're in the hospital is to get a sense of whether a patient needs to see a dietitian. A lot of times I ask a dietary staff here to see the patient. Do they need diabetes education? Do they not really know how to use their insulin pen, or I'm not really sure if they're looking at their syringe and kind of viewing it correctly. So at BIDMC, we now have an inpatient educator that comes to see patients that we deem necessary in the hospital, which is a big plus to the program that we have at BIDMC, I think. That's been there now for a couple of years, and I think it really enhances our level of care. And then routine things like ophthalmologists. Have they not seen an eye doctor recently? I usually try to ask these patients that when I see them. There aren't that many things I need to ask them, but I think that's one of those things I do ask them that because I'm not sure it always gets asked other times. So writing a sliding scale, I think it's an important thing to go over quickly so that we have an understanding of how this occurs. So patients, we try to come up with some amount of insulin that we think is a realistic level of a number of units for their total daily dose, or TDD. For type 1 patients, it's usually somewhere between 0.5 and 1 unit per kilogram per day. For type 2 patients, it could be anywhere from 1 to 2+ units per day. And we come up with a number called the correction factor, or the amount of insulin, or the amount of blood glucose, I should say, that 1 unit will drop the blood sugar. So if we say that for instance, if we come up with a total daily dose of 60 units for a patient, and that's based on one of these 2 formulas, the correction factor for that patient would be 1,500 divided by 60, or approximately 25 milligrams per deciliter. So that when we write a graduated insulin plan, or a sliding scale, if you will, every 25 points, we would give the patient 1 more unit of insulin, or every 50 points, we'd give the patient 2 more units of insulin. Similarly, an insulin to carbohydrate ratio is necessary for patients who are eating. And we take the same TDD, or total daily dose, divide that into 450. So for this patient, if the total daily dose were 60, it would be 450 divided by 60, which comes out to about 7 or 7.5. So 1 unit of insulin would match 7 grams of carbohydrate. So then the challenge is always to figure out, well, how much is the patient going to be eating? And sometimes when you see the patient Tuesday afternoon in the PACU, you can't really know what they're going to be eating Wednesday at lunchtime. But you kind of you make an educated guess. And I usually write a mealtime plan and a bedtime plan. And the bedtime plan I usually tell nurses or indicate in the orders to use if the patient isn't eating or is eating minimal amount of carbohydrate. And there's a little bit of of art also in that. So this is a sample plan using the numbers that we used before with an insulin to carb ratio of 1 to 7. This would be assuming that the patient is eating about 6 times 7 grams of carbohydrate, or about 42 or 45 grams of carbohydrate, which is like 3 carbs. So a slice of bread is 15 grams of carb. A glass of milk is approximately 12 to 15. So that would be, I think, a reasonable amount of food to expect someone to be eating. And that's the same for all the meals. At home, usually patients will have different scales for supper and breakfast and lunch because they typically eat more at supper than lunch, although some people have more carbohydrate at different meals. But notice here the BED, or the NPO scale, starts at a level of 200, and you could argue that it should start at 150 or 180 based on what we said earlier, but this one started at 200, and it's only a correction only scale. So if their blood sugar is 200 to 250, we're going to give 2 units, and with the previous example where one unit drops the blood sugar 25 points, this would bring the patient down about 50 points. And this kind of keeps things in relatively good control. This is an important graph, I think, to mention in most talks about glycemic management. And what it does is it's from a study from 2003. And when you walk into the room and you have a hemoglobin A1C, and you get one number, and the patient may be monitoring their blood sugars, they may not be monitoring their blood sugars, but before you even look at their blood sugar log, you know that if the A1C is in the low 7s or high 6s, the reason why it's not 6 or 6.5 is mainly due to postprandial glucose control. And so typically these patients will have blood sugars before meals that are right on target, 120, 130, 110. Yet their A1C, let's say, is 7.3, which in most labs would translate into an average blood sugar of about 160 or so. So the difference would be the postprandial rises in blood sugar. Whereas patients whose A1C is 11% or 10%, we would expect that they would have high fasting numbers. And we can also know that if we can do something to get their blood sugar in the fasting state down to the goal range, that we probably can make a big impact on getting their A1C from here down to here. So I think this is a useful graph to kind of keep in mind, at least for patients that I see, when this is what I spend my time doing, trying to get their A1Cs into range. I think it's a useful graph. And this is also a useful slide, I think, for anybody who manages diabetes. And what it talks about is clinical inertia. And that's essentially the failure to advance therapy when required. Now, interesting, Jocelyn has some professional education programs that I was involved in yesterday. And one of we're basically educating people who work for different companies who want to learn about diabetes. And one of the sessions that we were at yesterday, where it was in Albany, and they brought in 2 patients with diabetes to speak to the group. And one of the people who's running the program said, they had brought up to the patient different medications and what are your thoughts about them and which ones have you been on, et cetera. And the patient said, well, I was put on Resulin 15 years ago, which was taken off the market about 3 or 4 years after it came on because of liver failure. And I was put on Actos, and now there are issues with low bone density and bladder cancer and fluid and edema and heart failure. So the point is that he was very hesitant to accept new medications because he's kind of been burnt. He's lived through, he's seen a lot of different medications that he's been exposed to and had learned later on that there were adverse effects associated with these medications. And I think that probably applies to all specialties and all medications. So the clinical inertia is certainly, I think, a lot to do with the doctor and the provider. It also has to do with the patient. It has to do with both. And what this is showing is that patients who began insulin for type 2 diabetes, at insulin initiation, the average patient had an A1C of over 8% for 5 years and had an A1C of over 7% for 10 years. So for all these years, or you could argue maybe 4 out of 5 years or 9 out of 10 years, it was pretty clear that the A1C was not heading down in the right direction. It was not getting down to below 7, where at this time was certainly the accepted goal. Yet, for whatever reason, advances in therapy were not made. Insulin wasn't initiated, or even when patients were on diet, they weren't advanced to one medication. When they were on a sulfonylurea, they weren't advanced to dual therapy. So this is, I think, also an important thing for me to realize every day when I go into the clinic and I see patients who are not under control and really need a step up in their therapy to always keep that in mind. So I wanted to go over some typical or common consult questions. What do I do with insulin the night before surgery? So the first thing to do is to aim for morning surgery. Most people are NPO after midnight, whether they're having surgery in the morning or not. Usually we don't need to reduce insulin at night, certainly not to any great extent because they've eaten during the day. Make sure they in fact get their bedtime or their evening insulin, whether it's glargine, detamine, or NPH, or they will be heading to surgery with high blood sugars. And the surgeons and the anesthesiologist certainly won't be happy with that. A slight reduction is sometimes enough to give a margin of safety. So even though, in theory, we could give the full dose of glargine the night before, since it is a basal insulin, and in theory doesn't really take into account much of prandial coverage or cover any food. But in reality, sometimes it ends up being a little bit too much, so we decrease it a little bit, maybe 10 or 20%. And you also have to look at what the patient's blood sugars are typically when they wake up. If their morning blood sugars typically are 90 to 100, you probably want to lower the glargine dose the night before. If their blood sugars are typically 150 to 180, you probably can give the full dose. What do I do with insulin on the morning of surgery? Well, most people do not eat during the day, so less insulin will be needed. People need short-acting insulin only as a correction. So we talked about an insulin to carb ratio and a correction. They only need it with a correction. So using the bedtime scale, which we had discussed a few minutes ago, would be useful when they wake up in the morning the day of surgery. If their blood sugar is high, they should probably take something, but not their mealtime doses. Glargine, again, does not need adjustments because it's only providing background insulin, although sometimes we do decrease it a little bit just for a margin of safety. NPH should be reduced because it has that peak that we talked about at the beginning of the talk. And if we give the regular dose, it's going to drop the blood sugar around noontime, probably right in the middle of their surgical procedure. So usually lowering it by a third or half or even more sometimes is indicated. Why are those sugars so high? That's probably our most common consult question at the BI, DMC. If we take into account that basal insulin is usually about 50% of the total daily dose of insulin, so if we see a patient who is getting 60 units of insulin a day, but 50 of them are as glargine, that could be causing low blood sugars to occur between meals because they have too much basal insulin. Similarly, bolus is also about 50% of the daily dose. So if we see patients who are on 60 units and they're getting 25 units of Humalog or Lispro at each meal, and they're dropping low an hour or two after they eat, they're probably on too much Lispro. A typical regimen might be 30 units of glargine and 10 units of a rapid-acting insulin before a meal for an optimal blood sugar. Pre-meal bolus, as I had mentioned earlier, should always comprise a prandial component and a correction. So the dose should be different if their blood sugar is 200 before the meal versus if it's 120 before the meal. Sometimes that doesn't always occur, and that could sometimes result in high blood sugars at the next meal, just like they were at the previous meal. The most common error, and I think this comes again from this fear of inducing low blood sugar and using a correction-only scale, is forgetting about the prandial insulin component. I know it's something that I used to always never did before I was trained in this area, and I think it's something that we all do, and it's something to remember. And the scale at bedtime should be different since it only has correction and no prandial insulin component. And the benefit of that is it could be used at times of the day when the patient isn't eating or when they're nauseous or whatever. Why are those sugars so low? So a similar idea. Remember the time course of insulin, and if you give 2 doses of rapid-acting insulin within a couple of hours, something called stacking can occur, where the peak of the last shot coincides with the peak of the second shot, and blood sugar can drop. So we always want to avoid that. And mixes. I just saw this last week when I was on BIDMC. I think it's usually a few times a year, where somehow a mix, 70-30 or 75-25, gets written to be given at bedtime, which it should not ever be given because it has a fast-acting component. So we always want to give that with a meal. That's always very important to do. Bolus and basal should each be about 50%. I had mentioned that. And too much basal insulin leads to between meal low blood sugars. So occasionally we see patients in the hospital that we decide need to go home on insulin, right? So they're new to insulin. So what does a patient like this need to know how to do before they can leave the hospital? Certainly we don't need their blood sugars to be perfectly controlled, because even if they are perfectly controlled in the hospital, they're most likely not going to be controlled when they go home, because their level of activity is different, their food intake is different, everything essentially is different at home. So they need to know how to use a meter. They need to know how to store and administer the insulin, so keep it out of the heat, types of things like this. Don't leave it on the windowsill in the direct sunlight. How long can you keep it out of the fridge? After you start to use it, you can keep it out for about a month. It said all those things that a good nurse educator would go over with them. Type 1 patients need to know how to use ketone strips to detect if they're going into diabetic ketoacidosis. They should have some sense of what to do if they're sick, if they're not eating, if their blood sugars are high. They should have some idea of how to do that. And besides that, the rest is done as an outpatient. Diet, activity level are more realistically adjusted or determined when the patient is home. And again, my fail-safe is call if 2 blood sugars are over 250 in a row or on any day, or if any readings are below 80 for no obvious reason. I mean, if someone takes their insulin and then forgets to have breakfast, they don't necessarily need to call us. But other than that. Insulin in parenterally and enterally fed patients. So patients who are being fed by TPN, for instance, all the insulin to match the carbohydrate that they're getting should be put in the TPN bag. But the basal insulin should be given as basal, because if for some reason the TPN stops, then people forget to give the basal insulin and the blood sugars rise. So if we do both, insulin for the carb in the bag and sub-Q basal insulin, I think we usually cover both bases. Patients who are being enterally fed with an NG tube, in theory, all the insulin could be given as basal. But again, in that situation, if the tube feeds were to stop and we gave a big dose of glargine in the morning, they potentially could have low blood sugars when they're not getting any carbohydrate or any food anymore later in the day when the tube feeds have been stopped. So in practice, it's better, and it actually works. I think the control is better, and it also is safer to give half the insulin as basal and half the insulin as bolus, actually starting to having a scale that starts with some dose of regular insulin, even at a blood sugar of 100, because they're going to be eating. They're kind of like a patient that's continuously eating, so you want to give some insulin even if their blood sugar is 100. And I think in this situation, regular seems to work even better than Lispro or the rapid-acting insulins, just because it's a kind of a slower onset and it lasts a little longer, as opposed to Lispro, which is up and down very quickly. And these patients are usually getting fed continuously. If they're being fed only overnight or only during the day, then things have to be adjusted a little bit more. But for the typical patient who's on 24-hour feeds, this seems to work better. This is a patient that I wanted to go over. It's not a surgical patient, but I thought it brought up a lot of good points about steroid management. It's a kind of a segue into the last few minutes of the talk, where I'll talk about adrenal insufficiency management. This is a 60-year-old woman who I saw at the Beth Israel Deaconess, I think a couple of years ago now, on the oncology floor with a hematologic malignancy. She had a history of type 2 diabetes, was well controlled on metformin prior to her diagnosis. She was admitted to the oncology service for chemotherapy, and one of the treatments she was getting was methylprednisolone, 100 milligrams intravenously twice daily, and had resulted in hyperglycemia. And this is what I've tried to show you, the glucose values up here for the day. And this is 22 units of Lispro, 19 of Lispro, 19 of Lispro, and 65 units of glargine at night. And we were called right around here, I guess, when the blood sugar was 346 the next morning. They said, we need help figuring out what to do with her blood sugars. So what are the recommendations? Well, we could The patient's on 65 units of glargine at night. It's a basal insulin. It works throughout the night. We could say, let's increase the glargine by 5 more units. We could increase the glargine, saying, well, the blood sugar was 346. 5 more units out of 65, that's not a big percentage. That's maybe a 8% increase, yeah, 8%. So let's go up by 20 units. We could say this patient needs to be transferred to the unit, which is what we would have to do there. She needs an insulin drip. We could add NPH insulin, which typically works very well when patients are on steroids, which is what I did recommend. Or we could increase the Lispro scale, which wouldn't make much sense if the blood sugar were high in the morning, because she's not really getting much Lispro overnight, or not getting any Lispro at all overnight, just a little bit at bedtime if she were high. So that's what I did. I added NPH insulin over here, and lo and behold, the next morning, I was surprised that her morning blood sugar was down to 97. So a big drop just from 15 units of NPH. Now, if you remember, the NPH insulin peaks. It's not like glargine, which is flat. It does have a peak, so that's why we typically tend to use NPH when we're using steroids. But it was a little bit more than I thought. So what I did the next night was I said, let's give only 10 units of NPH, since 97 in the hospital is sometimes a little bit too low for comfort, too close for comfort, too low, basically. And that was kind of where she was in terms of the next week or so. So if we jump forward from July 31st to August 6th, she was now getting methylprednisolone 60 milligrams in the morning, 40 milligrams in the evening. Somewhere along the way, we had added some NPH in the morning, I think because her blood sugars must have been running high in the afternoon. She was still getting the same 10 units of NPH in the evening, and we had actually, over here, I think I forgot to mention I had lowered her Lantus a tiny bit as well when I added the NPH. So she was still getting that 55 units. And then all of a sudden on August 8th, her blood sugar is 287, and we're told that she's going home today. And we're changing her to Perioprednisone, 100 milligrams in the morning. So they're going to take all these 100 milligrams here and give it to her in the morning. And what do we do with her insulin plan? You're laughing. Probably happened to you also, right? So what do? Do we decrease her evening NPH, because she's not going to be getting any steroid at night? Do we increase her morning NPH, because she's going to be getting more steroid in the morning? Do we do both? Do we add Lantus in the morning? Or do we decrease her Lantus? She's getting all this Lantus at night. Do we decrease the Lantus at night? So I'll tell you what I did and what went wrong. My plan was to tell her to take no NPH at night, so to get rid of these 10 units. Because when I had first seen her, she seemed to have been doing well with this Lantus at night. I kind of said, okay, well, the change I made was adding the NPH. Let's just leave the Lantus as is, and let's increase the NPH in the morning, since you're going to be getting more prednisone in the morning. You could argue that 2 units of an increase was kind of a wimpy thing to do. She probably needed more than 2 units more if she's going from 60-40 to 100 milligrams in the morning. But be that as it may, that's what I did. And lo and behold, what happened was that her morning blood sugar the next morning at home was 47. Now, why was it 47? So she was actually one of these arrangements where she came in for chemotherapy to one of the places at BI, so they kind of called me. I was on service. I went over to see her. And I think what happened was that I really didn't realize that all this glargine that was on board before I even met her was really covering the prednisone, or the steroid, the methylprednisolone that she was getting at night. And a lot of times when patients are getting steroids twice a day, when they're getting steroids, well, either once a day or twice a day, they become adrenally insufficient because they've been on long-term steroids. And whereas normally all of us would be producing cortisol in the morning, this patient was probably producing very little cortisol overnight in the morning. She was getting a big whop of prednisone in the morning, and it kind of lasted throughout the day and maybe a little bit overnight, but she was both getting extra insulin. She was both getting insulin at night that she probably didn't need, and she was probably making a little bit less cortisol the next morning. And that was probably what resulted in her low blood sugar the next morning. So what I did at that point was I told her to get rid of the glargine at night. So don't take this at night anymore. There's no glargine there. Take it all in the morning. And with that, we would expect her glucose control to be much better. And at some point, her prednisone was changed, and I'm not sure what happened after that. But I think this brings into light a few of the a few of the issues that we talked about with or low blood sugars, high blood sugars, how to manage things with steroids. That brings me into what I was asked to talk about a little bit of adrenal insufficiency. I don't really think I'm an expert in it. I don't manage it very often. At the BIDMC, the endocrine service manages this. I do a little bit of it here, but I think the hospitals probably do more than I do. But I'll just bring up some of the issues that came up in my reading in preparation for the talk. Perioperative steroids for patients who are truly adrenally insufficient. For minor surgeries such as hernia surgery, the recommendations are to give hydrocortisone 25 milligrams a day just on post-operative day number 0, and then to resume the normal steroid regimen. For something in between a major surgery and a minor surgery, such as a joint replacement or a cholecystectomy, the recommendations are for hydrocortisone 50 to 75 milligrams, both on the surgery day and on post-op day number 1. And on major surgeries such as CABG, the recommendations are for 100 to 150 milligrams of hydrocortisone per day. This is, of course, spread out 2 or 3 times a day, I believe, and to give that on post-operative days surgery and for the next 3 days post-operatively. Patients who are to be considered as not having a suppressed adrenal pituitary axis. So patients who are on steroids but are not to be considered as suppressed patients are patients who are on less than 5 milligrams of prednisone a day, or if they've been on exogenous steroids of any form for less than 3 weeks. We assume that their endogenous cortisol production is still there, is still intact, I should say, or if they're on less than 10 milligrams of prednisone every other day. So these are patients who you can assume do not have a suppressed adrenal axis, whereas any patient who's been on prednisone for equal to or more than 20 milligrams a day for more than 3 weeks is certainly adrenally insufficient, and everybody else in between is we're not really sure. So we can't assume that they're suppressed. We can't assume that they're non-suppressed. If we check a morning cortisol and it's less than 5, they're suppressed. If it's greater than 10, they're likely not suppressed. And if it's anywhere between there, we should certainly do an ACTH SIM test. And I think even if it's a little bit above 10, we tend to recommend doing that as well. If they stim at 30 minutes to less than 18, that's abnormal, so they're to be considered suppressed. And if it's over 18, we usually consider them to be normal. Now, if patients have had a recent insult to their pituitary gland, surgery or trauma or something, within the last 2 weeks, you would expect that their adrenal glands are not atrophied, they're still functioning, but they just don't have enough ACTH because their pituitary isn't working. So in that situation, since it's very difficult to assess for that with, I'm not even sure if metyrapone is available anymore, but I think it's difficult to do, and an insulin tolerance test is probably the gold standard of doing that also, and measure cortisol and ACTH levels. Those are very difficult to do, so the recommendations are just to assume that the patient is adrenally insufficient and treat per the protocol that we had mentioned a few minutes ago. So we should be evaluating patients for adrenal insufficiency if they're on fluticasone greater than or equal to 750 micrograms daily for at least 3 weeks within 3 months of surgery. So that's enough reason to assume that they might be adrenally insufficient, and we should do usually a cord stim test. If they're on any other type of inhaled corticosteroids above 1,500 micrograms per day for more than 3 weeks prior to surgery, we should be evaluating them. Or if they've had, which is probably relevant to a lot of our patients here, 3 or more intra-articular or spinal steroid injections within 3 months of surgery, they technically should be evaluated. And evaluating might be just checking a morning cortisol with their pre-op labs, would probably be a useful thing to do. So I always end my talks, or I try to end my talks with something to kind of remind us where we've come in the last now almost 100 years, at least in insulin therapy. Near this spot on August 7th, 1922, Dr. Root, in the presence of Dr. Elliot Joslin and others, gave the first injection of insulin in New England. The patient was Miss Elizabeth Mudge, who with insulin was restored to health and lived for 25 years thereafter. So from that point, we now are asked by Dr. Joslin, Elliot Joslin, can we achieve the goals of diabetes therapy in 2014? And hopefully, if he were with us and alive, he would say yes. So thank you very much for your attention. And if there are any questions that I could try to answer, I'll try to. Yes.